Hello, welcome to my channel, the blue AGACNP. I actually just graduated and will be taking my board soon. To study, I am putting together different PowerPoints for the different subjects and using the Berkeley review course that I took, the manual, and some other review course material from other authors that I will cite at the end of this presentation. This is just a review of the most important subjects that I identified that will be on the test. So I wanted to make sure that I could share it with you guys, and let's go. I wanted to get started with anemia and what the definition for anemia is, and it is the reduction below normal levels of erythrocytes, hemoglobin, or volume of those red blood cells. And the reasons that people get anemia are like blood loss, maybe there's bone marrow failure, or the bone marrow has some kind of impairment in the production of red blood cells, or hemolysis, there's some kind of destruction of red blood cells going on for some reason. So erythrocytes, which are the same thing as red blood cells, are the cells that contain hemoglobin. And hemoglobin is normal at levels 12 to 16 for females and 4 to 18 for males. It's actually a protein, and it carries the oxygen, and that's what gives the actual red color to blood, and that's why you will see that arterial blood has a brighter red color to it versus the venous blood, which is a darker red. It's also important to remember that it is a main component of red blood cells, hemoglobin is. The hematocrit is the percent of erythrocytes in a given volume of whole blood, and the amount of plasma to total RBC mass, which you can consider it as the RBC concentration. The reason that you'll see males have higher H and H's, or hemoglobin and hematocrit, is because they have a lot more testosterone than females, and testosterone actually stimulates erythropoietin production, and that stimulates red blood cell production in the bone marrow, and so that's why. And again, hematocrit 37 to 47% is normal for females, and 40 to 54% is normal for males. There's also serum iron that we measure when we are looking for anemia. After, first it would be your H&H. You notice that it's low, and if you suspect that it's anemia, then you would go ahead, and if it's like maybe you think it's iron deficiency anemia, you could go ahead and get a serum iron, ferritin. That's why they are here, and 50 to 150 is normal for serum iron, and ferritin is 12 to 150 in females and 12 to 300 in males, and the ferritin is the actual iron stores in our body. I like this picture over here because it kind of gives me a visual on what an erythrocyte would be, and how those hemoglobin are connected with iron to that erythrocyte. It's actually within the erythrocyte. Some general concepts about anemia continued with some values is the total binding capacity, which is 250 to 450. So this is going to increase when there is actually a higher need for iron. So when you have like low iron stores, the total iron binding capacity will be higher. The mean corpuscular volume, or MCV is what I'll call it, is 80 to 100. This is actually the size of your red blood cells, and the expression of average volume and size of the individual erythrocytes. the mean corpuscular hemoglobin, which is MCH, 26 to 34. This is actually the weight. It's the expression of a hemoglobin's average weight in one erythrocyte. And the mean corpuscular hemoglobin concentration, which is more accurate when we're evaluating for anemia, is 32 to 36% as a normal value, but it is the average concentration or the proportion of hemoglobin occupied in one red blood cell. And there's some different meanings that we will be using with these, and like the MCHC that we just talked about is going to give you the RBC color, or it's the chromic value, and it helps us identify anemia. So just so we know, normal chromic is 32 to 36%, hypochromic is 32%, I'm so sorry, less than 32%, and then hyperchromic is greater than 36%. So the MCV will give you actually the RBC side like we talked about. So that's like the cytic, like so normal cytic is going to be 80 to 100, and then for anemia of chronic disease, sickle cell, renal failure, blood loss, and hemolysis, all the anemias for that's going to have a normocytic RBC. For low MCV, which we call microcytic, that will be a smaller size of the red blood cell, and the anemias that have that are the iron deficiency and thalassemia. We also have what's called macrocytic anemias, where the MCV is high, and the anemias that are macrocytic are B12 deficiency, folate deficiency, alcoholism, and liver failure and drug effects. This is also called megablastic anemia. So when we're evaluating for anemia, the specific values that are important are your total iron binding capacity, so make sure that you know that, and then your mean corpuscular volume, or your MCV, and then your MCHC is also important values that will help you identify which anemia you are looking at. So the first one I wanted to talk about, and the first one that I really find is important, and I do believe it's one of the most common ones that you will find in the anemia categories, is the iron deficiency anemia. Again, number one common cause of anemias is iron deficiency anemia. This is usually indicated by a hematocrit less than 30%, and it's going to be caused by different reasons depending on the patient and the patient's history. So blood loss, slow blood loss, like a patient that's taking NSAIDs and may have like a little GI bleed. Dietary inadequate intake, so malnutrition could be a reason. And then impaired absorption of the actual iron could be the reason due to some kind of GI disorder. So the signs and symptoms that you see usually with iron deficiency anemia is a little bit slower in actually developing, but the big one is pica. This is that weird food cravings. Usually it's like ice or clay cravings. I've seen people eat dirt. So these are really big indications that the body needs iron. Dyspnea with mild fatigue with exercise, headache, tachycardia, palpitations, weakness, postural hypotension, and pallor are all common symptoms of iron deficiency anemia. And the labs that you're going to see, remember, we're looking at the size and the color and the binding capacity of these hemoglobin molecules. So a low MCV and a low MCHC, but you'll see a high TIBC. And that's going to be your indication that this patient has an iron deficiency versus a different one that we may go over later. But the high total iron binding capacity being greater than 450 for a patient that has a low H&H would be an indication that possibly that patient has iron deficiency anemia versus a different anemia. But of course, you would be ordering these labs after your H&H is low and you're trying to figure out what kind of anemia you have. So the iron deficiency anemia is categorized as your microcytic, hypochromic, and this is going to be managed and treated with iron. Oral ferrous sulfate at 300 to 325 milligrams daily. There are some studies that say that you can take it every other day if it is not tolerated, but you take 1 to 2 hours after meals. So iron taken with meals, the iron is actually decreased by 50% when you take it with meals. That's why they want you to take it 1 to 2 hours after meals, and you shouldn't take them with antacids. And if you can have a source of vitamin C while taking it, that's going to increase the absorption of that iron. There's also foods high in iron that you should be telling your patients to make sure they are consistently using and eating in their diet. So those will be like raisins, green leafy vegetables, red meats, citrus, iron fortified breads and cereals, which is like a big thing that I think works for a lot of people, are those cereals, because, and make sure that they're looking at the nutritional values and the iron is actually in there. So again, that high total iron binding capacity is important for us to remember to look at if we are suspecting any kind of low iron or iron deficiency anemia. I really wanted to talk about the hemoglobin real quick because, like, for me, it's really important for me to understand what I'm looking at or what I'm trying to find. And there is a hemoglobin A1. It's called a hemoglobin A1, or it's also called, you may see HbA as used as its name. But this is the hemoglobin that actually makes up 95 to 98% of the hemoglobin in adults. With that being said, it has two different protein chains. Two of them are alpha chains and two of them are beta chains. And sometimes there's some genetic mutations that occur with these chains, and it results in a different kind of hemoglobin. Like an altered hemoglobin S is found in sickle cell disease, and then there's a decrease in globin chain production and thalassemia. So it's really important that the basic functioning of this is understood, so that way when you're trying to find these in your patients, it's easier for you to understand that if one normal beta gene and one abnormal beta gene are inherited by a patient, that person is actually heterozygous for the abnormal hemoglobin. If two abnormal beta genes of the same type are inherited, that person is homozygous. So the most common signs and symptoms for anemia in general are fatigue, pallor, dyspnea, palpitations, bounding pulse. The signs and symptoms with hemoglobin variation anemias is very, very similar, but you are going to see a breakdown of breakdown of red blood cells, which is hemolysis, and there will be a shortened RBC survival. This is what leads to the anemia for patients that have hemoglobin variant anemias. The signs and symptoms for those patients, similar to those for any anemia, would be weakness, fatigue, lack of energy, and then you may see some jaundice due to the high amount of hemolysis occurring, and then pale skin and pallor. So there are some other hemoglobins, like there's hemoglobin A2 and hemoglobin F that you can read there. I also put the source of where I got this, as you can see right there. This is a really good site on this information, and I wanted to share it with you. So leading off that last slide, I did go ahead and look at thalassemia anemia, and this was really interesting to me. It is also microcytic, just like the iron deficiency anemia, and hypochromic. Again, remember we looked at the total total iron binding capacity, which I have it backwards here. But in this one, it's normal because this isn't an iron deficiency. This is actually a genetic mutation of that hemoglobin, and it's not going to show the same labs. So I just wanted to put that out there. So again, thalassemia anemia is found in mostly like Mediterranean background patients, but African, Middle Eastern, Indian, and Asian populations all have the trait of this. And it's caused by reduced or absent production of beta globin chains, and globin part of HbA has that 4 protein sections called polypeptide chains with 2 alpha and 2 beta chains that we talked about in the last slide. So with thalassemia minor, 1 copy or a heterozygous for beta thalassemia occurs, and this is a mild anemia, and it's not 2 which is normal. It's the actual abnormal ones. And the thalassemia major, it's also called Cooley's anemia. So if you see that on the test, again, that's thalassemia. And it's the more severe type of the thalassemia. It's called thalassemia major. And that's when 2 genes for the beta thalassemia and no normal beta chain genes are there, and that's called homozygous. Normal presentation at birth, so these patients don't seem to have a big problem when they're first alive, but that's due to the mother's, protection she's given in vitro. But within the few first months of life, they start to have severe anemia signs and failure to thrive. They have feeding difficulties due to fatigue or lack of O2, bouts of fever, diarrhea, maxillary problems. So definitely something that is not being observed in the adult population at first, but will carry on later into their lives. The labs that you will see on these patients will also be that they have a low MCV and a low MCHC, which we saw with the iron deficiency anemia. But again, they will have normal serum iron. They will have a normal total iron binding capacity, and they will also have normal ferritin levels, and they will also have a low alpha or beta hemoglobin chain. The management for these patients, really, if it is not a big thing that they can do for anybody that has like a mild or moderate version of this, but splenectomies have been needed for patients that have the more severe cases, and RBC transfusions for severe anemia. But the thing that I want to make sure that everybody understands is if your patient has thalassemia anemia, giving them iron is not going to help them, because remember, it's not that their iron stores are low or they don't have a iron binding capacity. It's just that it's a hemoglobin issue. So if you give them iron, they're going to go into an iron overload, and that's going to actually cause more problems. And it's probably not a good idea to ever give iron unless you have physical evidence that they're low on iron. The prenatal genetic testing of a parent can be done if they're worried about, delivering this to their or giving this to their offspring. Okay, so that was the microcytic ones. I wanted to, and microchromic. I wanted to talk about folic acid deficiency anemia, which is a macrocytic and normochromic anemia. This is definitely just an intake issue. Again, folic acid is needed to make red blood cells. And the causes, again, for this is because the patient is either not ingesting enough folic acid or they're not absorbing it due to whatever intestinal or GI issues they may be having. But mostly the inadequate intake is because usually this is a dietary issue. that you see, like maybe that homeless guy that's eating out of the dumpster, or maybe it is a schizophrenic that has not been able to maintain medication compliance and now they just are manically or in psychosis and they're not eating properly. Substance use disorder patients and eating disorder patients are very high on this list too. So folic acid deficiency, look for those in those patient populations. The signs and symptoms about this one, I just want to point out there's no neuro signs and symptoms when it's just a folic acid deficiency anemia, but you will see glossitis, which is a huge, like that red beefy tongue, a big indicator of this diagnosis, and other things like fatigue, dyspnea, exertion, pallor, headache, tachycardia, anorexia, which may be related to an eating disorder. And then they also have this thing called aphthous ulcers. So just something to look at and think about on the boards if you find that your patient is being identified with these presentations. Lab-wise, these patients will have a low serum folate. The RBC folate will be actually less than 100. They're going to also have a low H&H because obviously if you don't have enough folic acid to make red blood cells, you're not going to have enough red blood cells, which makes you anemic. And then they will have a high MCV, which is called macrocytic anemia, and their MCHC will be normochromic. The treatment for these patients, really easy. When it's easy, right? And it's folate, 1 milligram daily. And then we want to encourage them to eat high folic acid foods, and give them education that those could be bananas, peanut butter, fish, green leafy vegetables, iron fortified breads, and cereals. Again, that's like the easiest and easiest ones that I always recommend to my patients. Which of these would you do next for labs that came back on your patient with an MCV of 98 and a folate of 22? So MCV 80 to 100 is normal, and then folate is 100 or greater for normal, or greater than 100, I believe. And so I would do A and B. I would check a pregnancy test to see if the patient is pregnant and has low folate for that reason, or check to see if the patient has low dietary intake. I would not give RBCs or cryo. Yay! This is pernicious anemia, which is B12 deficiency. It is a macrocytic normochromic anemia, and it is because of a malabsorption issue and a deficiency of intrinsic factors that cause the malabsorption of B12. So again, pernicious anemia is a malabsorption issue. And then with pernicious anemia, you have signs and symptoms of glossitis, like folate deficiency, but this one involves neurosigns like paresthesia, loss of vibratory sense, loss of fine motor control, positive Romberg, positive Babinski, also weakness, palpitations, dizziness, and anorexia. Labs will show you a low H&H. You will have a low serum B12, which should be less than 200, and then you have a high MCV, which makes it macrocytic, and a normal MCHC, which makes it normochromic. An anti-intrinsic factor and an anti-parietal cell antibody test would be something that to look for. And then the treatment is going to have a front load of B12, 100 mics, IM daily, times 1 week. And then you want to do a maintenance dose, and this is lifetime B12 IM monthly shots. Question: what causes pernicious anemia? What do you think? Well, if you said malabsorption of B12, you were correct. It's due to the deficiency of an intrinsic factor, so it's very hard to absorb B12 for these patients. Now let's review the anemias of chronic disease. Chronic normocytic normochromic anemias. So since these anemias are chronic, just like everything else in our body, somehow our body compensates in different ways. So the normocytic normochromic portion of this makes it a little harder to identify, but it is the most common anemia in hospitalized elderly patients, and it is the second most common cause of anemia in general. The etiology usually is a chronic inflammatory disorder. Chronic infections are big with this, like sepsis. Autoimmune diseases like rheumatoid arthritis are big identifiers that this patient may have an anemia of chronic disease. And renal or kidney diseases, cancers are also big on this list, and it occurs acutely if there is some trauma or it's like a post-surgical reaction. So, but mostly it's a chronic issue. There's 3 pathophysiologic mechanisms that occur with anemia of chronic disease. So either there is some reason that there is a decreased erythrocyte lifespan, or hypoproliferation. Erythropoiesis is impaired due to decreased epoetin production and bone marrow response, causing altered iron metabolism due to the hepatic hepcidin, and inhibiting iron absorption and recycling, which gives you that iron sequestration. And I think that the signs and symptoms are very vague and same as you would see it with the other anemia. So you're going to see that fatigue, weakness, dyspnea on exertion, and anorexia. Now, these patients are those that you see a low H&H, but their MCV and MCHC are normal. So you may see the serum iron and total iron binding capacity to be low, and then the serum ferritin is high. So it's going to be greater than 100. So the stores of iron are high, but the actual iron and total iron binding capacity are low. And the management for this is honestly just treating the associated disease. In kidney disease, anemia occurs when there's actually a creatinine clearance that's less than 45 in that milliliter per minute, and then the other value there, as you can see. It is important to provide nutritional support for these patients, and if needed, long-term epoetin injections can be considered. Again, this is a hypoproliferation anemia, and it's when the erythropoiesis is impaired. Decreased erythropoietin are all indications that, and having some kind of chronic inflammatory process also is an indicator of this anemia. One example is that sickle cell anemia. Again, this is a chronic hemolytic anemia, and it's a homozygous RBC in sickle cell shaped hemoglobins, with the cause being genetic. The factors that precipitate sickling in these patients is things that happen are like hypoxia, infections trigger this, high altitudes, dehydration, physical and emotional stress is a big one. Surgeries, any reason for blood loss, and if the body has an acidosis, these could all trigger sickle cell
crisis. So what happens is in an acute exacerbation, the RBCs are turning into a sickle shape, and when the shape changes, it actually like gets stuck in the blood vessels, and it causes an occlusion to whatever site is supposed to be being fed by that vessel that's being occluded, and causing now tissue ischemia of that site. When the tissue ischemia occurs because of the sickling shape of these hemoglobin, the patient is in severe pain, and the blood is going to be hyper viscous. And this is a very big, painful disease, and it is hard for these patients because it actually develops in childhood. You will see delayed growth and development in these patients, and chronic spleen damage that I was talking to about the prior in the prior slide, where they have to have a splenectomy, could be a reason in sickle cell anemia. And the ischemia also causes severe pain in these patients, again, remember. And then priapism is also a big sign that you may witness with your patients that they complain about in these situations. The number one sign and symptom in sickle cell anemia crisis is that they complain about aching joints. Aching joint pain is very common, and then they have the sudden onset of the severe pain. It's usually also in their extremities, back. You'll see a lot of chest pain in these patients, which is a whole different syndrome that happens. And then they also have a lot of pain in their abdomen. Weakness, dyspnea comes with it, and the treatment is simple transfusion during aplastic crisis or a splenic or hepatic sequestration. The acute phase of this is going to involve the patient getting lots of fluids, lots of analgesia, and oxygen, because remember, it's happening, this pain is happening due to ischemia of the tissue. What I learned during the review course was that a lot of these patients will always tell you that they are allergic to Toradol, just because of the medical trauma they probably have from being mistreated and not given the proper pain medication, and just been left, in pain. And so they don't want you to give them Toradol because they already know that Toradol is not going to help them. Now, Dilaudid is one of the most amazing analgesics that help in this situation. But what I learned in the class was that if you just tell them that you're going to give them Dilaudid for the pain, and if you could also additionally add the Toradol to the Dilaudid, it could immensely help them more than just giving them the Dilaudid, because the Toradol actually relaxes the muscle, and then the Dilaudid is the analgesic that kind of works on top of that, and it provides a more thorough pain relief for those patients. So just kind of something that I thought was important and I took note of. With these patients, again, hemoglobin is decreased, and then you would need to see a peripheral smear of this patient to diagnose that they have the distorted sickle-shaped RBCs. Remember. So what occurs at the lung bases and the tissue on a hemoglobin dissociation curve is something that I think it is important for us to know. I think that it's something that we commonly hear is the shift to the right. This is when the hemoglobin has reduced affinity for oxygen, and it's making it easier for the oxygen to be released. Okay, so that's shift to the right. Acidosis, shift to the right. But let's look at the lung bases. So during normal pH at the lungs, there are oxygenated blood that is left with the alveoli. So we breathe in, and the alveoli absorbs all our oxygen from our breath. The oxygen then binds to the actual hemoglobin. And guess what? You have an increased SAT or SaO2, and you have an increased PaO2. Now, at the tissue level, though, so this is after the lung has binded the oxygen to the hemoglobin, and your SATs are increased, your SaO2 is increased, and it's delivering it to the tissue. Now, it gets to the tissue, and O2 leaves the blood, right? Because it has to go into the tissue. This is when O2 is dissociating with the hemoglobin after it has entered that cell. So it goes into the cell, the hemoglobin goes into the cell, gives the O2 to the tissue. Nice, right? And then when you have the oxygen already delivered to the tissue, the hemoglobin leaves, and now you have a decreased SaO2 and a decreased PaO2 because it's been delivered to the cell, right? And I already kind of talked about the dissociation curve. If it happens to shift to the right, what happens is whatever's causing this dissociation curve to shift to the right, acidosis, is actually making it easier for the oxygen to be released at that tissue level, right? Or honestly, at any level at this point, because hemoglobin has a reduced affinity for the O2 at that point. So when you have this shift, it's usually caused by an increased CO2 in the blood. And we know that CO2 turns into an acid once it's in our bloodstream. And this could happen in just normal routine exercise time. And, you know, that's why we like exercising for patients, because it's going to help them increase the metabolic activity of their whole body, including the hemoglobin. And it lowers the pH, and it causes a little bit of acidosis, which causes your patient to have the ability to give more oxygen to the cells. The higher temperatures in tissues also cause this acidosis, such as like a fever. And then high altitudes in chronic anemias have a increase in 2,3 DPG, and then that decreases the hemoglobin's affinity for O2. So that's another reason. And then increased metabolites like hydrogen or lactic acid also cause this acidity in the body that would cause the rightward shift of the oxyhemoglobin dissociation curve. I just wanted to put that out there because I think it's important that we understand that this is happening and why it's happening and what the acidosis does. And so if you can imagine, alkalosis would give you the opposite effect, where the affinity of the O2 increases, right, to the hemoglobin. So just something to keep in mind. I wanted to just share that with you guys. Next.